Well, I was interested first in infectious diseases when I was a resident at the University of Minnesota, and particularly the VA hospital where one of the ID guys kind of took me under wing. And I also had an experience with a famous ID person there, Wesley Spinks, who was the grandfather of Brucella. Well, it turns out Dr. DuPont, my mentor, had also been a resident there and had gone on to Baltimore, where he was considered a rising star and had been recruited down to UT here in Houston. And my mentors there said, you should hitch your wagon to that star. So I came down and interviewed, and Dr. DuPont is very persuasive. He's a good recruiter, and I was hooked and never looked back. So he's been such a mentor for me and so supportive in my career. I couldn't have asked for a better person to hitch my wagon too. So he's enabled me to grow as an academician, as an educator. It's hard to emulate him, but you can learn from him at any rate and come close to emulating him. So that's why I came here and why I decided to stay when he offered me a job to be on the faculty. Well, I arrived in '75 and did my first year of fellowship. I was the second group of fellows and the only one out of the initial four that decided to go into academia and stay here at the school. Then my second year, I was given the honor of being appointed an instructor in medicine. I look back on it now and realize that got me off the soft money and put me on the hard money. So it was a good move for Dr. DuPont, but it was a feather in my cap, and I loved it. And then later, of course, I was appointed an assistant professor and then moved on from there. Well, I think in large part one stays because you're successful, you continue to have a support system, and I certainly did in Dr. DuPont and among excellent colleagues that he had surrounded himself with. He took me under wing, gave me opportunities in research that I don't think I would have had without his presence. I think later it became clear that as I advanced up the academic ladder, that I had to establish more independence and move away from him and under his wing a little to show that I could do it on my own. And I did, but my first love had always been and remained working with traveler's diarrhea with Dr. DuPont. And I think that's where I had my major impact as an academician. But I kind of got off on a tangent, if you will, to show some independence with surgical prophylaxis and clinical studies here at the school with a surgical colleague. And that got me the independence I needed to get promoted. But once I got to that, I went right back to pursuing traveler's diarrhea studies with her. Well, there's a number of things that I am proud of, and I think Dr. DuPont asked me one time, "What do you want to be when you grow up?" And I think my tombstone ought to say, he was a good educator, and I thoroughly enjoy that part of it. I'm not an NIH style researcher. I'm not going to have big grants brought in. The research I did that got funded was with drug companies pursuing studies about the surgical prophylaxis. But I did earn some teaching awards, including one even from the basic science students, which surprised me, but I guess just because, I had some humor in my lecture, I suppose, I've subsequently gone on to leverage the work we've done in traveler's diarrhea, which is probably one of the more common maladies amongst travelers, to set up the travel clinic enterprise here at UT, and I'm proud of that, and particularly proud politically of how that segued into an international experience with the International Society of Travel Medicine. So that enabled me to get into that and even become the founding editor of a journal of travel medicine, again with Dr. DuPont's help to get it going, but that was my baby, and I'm quite proud of that baby and the fact that she's doing very well. Lately, I've developed a strong interest in what's called antibiotic stewardship, where physicians need to come through our program in order to use expensive antibiotics, but not just that, those that we would really prefer to keep in reserve because they're absolutely necessary for resistant organisms, and fostering the judicious use of antibiotics so that we don't lose our antibiotics, which is easily done if you're not careful about how you use them. So, I think that is something I've been pretty proud of as well. So there's several things as I've grown up, that I think I've had an impact, and I'm certainly proud of what impact I've had. Well, one of the things I did administratively is served on the Committee for the Protection of Human Subjects, and certainly that impacted me considerably in my research with human subjects, which we did a lot of down in Guadalajara, Mexico, doing our travelers' diarrhea studies, in helping me understand the ethical conduct of research and bringing the ethical care concepts to the teaching of my students and how to be a good, compassionate physician. So I think that was a very useful experience for me and helped me grow in that regard in being a more compassionate physician. And I think, the school just consistently, had the substrate to make me a better clinician and an educator. So some of the TV work I did at one point where I was a host of a medical education show, those folks, for instance, were very good about, oh, wait a minute, that slide is way too busy, make it just a few bullet points. And, that sort of opportunity is strong here at this school to be collaborative and help one another. And it was for a lot of those reasons I would never leave, It's just a wonderful environment to be in. The medical school has changed a fair amount. The beginning days were organized, the school was organized in programs. And for instance, Dr. DuPont was the director of a program of clinical infectious diseases as well as microbiology. So we had adult infectious people, pediatric infectious people, clinical microbiologists all under one roof. That was wonderful for fostering a research enterprise and the collaboration and the education. And to this day, our clinical conference has both pediatric case presentations as well as adult presentations, which I find invigorating. And I think that way our fellows kind of hear both sides of the story and can become better teachers themselves, because they appreciate how age, affects the various infectious diseases. So that changed over time, as the initial people who were forward-thinking and could collaborate and build those enterprises moved on to other places or needed to be replaced for whatever reason. People coming in didn't understand that very well, and naturally they went, well, wait a minute, I don't understand that. I just want to be the department chair of something. So it didn't take too long before it sort of devolved into the more traditional lines of the medical school. And that's probably okay because the people that were coming in understood that and knew how to grow within that range, but they didn't know how to succeed and grow in a programmatic approach. I've seen a lot of changes over time in the medical students, and I can hear maybe some of the millennials right now saying, "Okay, boomer." That's apparently the latest thing. And but I sense a somewhat fundamental change in the attitudes of young doctors toward their profession. On the one hand, I think there's more time devoted to personal development and family and so forth, and one can't deny that that's important. We certainly now don't work residents to death and expect them to perform, when they're dog-tired, the way a lot of us had to, and I wonder sometimes I didn't crash my car going home at night, But on the other hand, we, in those days, as we grew up as physicians, we were sort of duty-bound to really take care of that patient, to to hand them off to somebody when they were in good shape and you knew what was going on. You didn't call a consultant, for instance, unless you had really gotten to the point where you had done your best to work up the patient and applied pathophysiological reasoning to your patient, and have a rather subtle question to ask a consultant coming in. I see young people, perhaps driven in part by wanting to work an 8 to 5 sort of job as a hospitalist, becoming triage officers. They're very good at recognizing what system they're in, and then because, particularly with a hospitalist, they're not going to see the patient as an outpatient later, they call whoever needs to be called in to take care of that problem, and who then can arrange for a disposition for the patient. So the concept of a generalist who really is a pretty good dog of all trades is starting to fade off. Some of that's driven by the fact that medicine has become quite complicated. But some of it, I think, is also just this different attitude of how you take pride in your education to be able to solve problems or get the solution to a certain level before you have to call in help. Because if you want to triage something always to subspecialists, that's going to increase the cost of medical care. So I think we have to be more concerned about that. I also see young people with this attitude, if you can't image it, it must not exist. So right away they just want to get a lot of imaging studies, and if they can't find it that way, they've sort of lost the focus of first taking a history and doing a physical examination, and the astute, experienced physician may not need to get those imaging studies. They may be able to understand right away what's going on. So I think we owe it to our trainees as more senior physicians to keep pushing them to be thinking critically about their patients, and having pride in the fact that when they've called somebody in, they really needed the help. And even the specialist is going to be a bit challenged, helping you with that kind of case. I think maybe as physicians get out into practice and realize they can't just send everybody away and to their specialists, they probably change a little bit. But we in medical school, I think, ought to be a little more critical of, well, why did you call somebody in? Or the general attendings, I think, need to be in the driver's seat more, not just to let a trainee ask for a consult so they can shine later before they're attending, but to prove that, was that even necessary? Wait, I as a well-qualified internist could get further along with that before you called in the specialist. So that's sort of something that's changing, and we just need to be aware of those currents, I think, as we, as professors, try to do a better job teaching people. My strongest memories of medical school probably relate to the research we did down in Guadalajara. Those were wonderful times, and sad that we had to leave them because of all that foment going on in Mexico, where finally the university put their foot down and said, we don't want you going down there because we're afraid you're going to get killed. And we argued and said, well, but it's on the border and this and that. That was the first year I was going to maybe get a chance to go to Cuernavaca, which is a lovely kind of nestled in the mountains town just outside of Mexico City, where it's a retirement community. And there's language schools down there, so we had an enterprise for research there. I was looking forward to the change. Until an article came up in the newspaper saying 5 heads found hanging from an overpass in Cuernavaca. My wife stepped in and said, you are not going. And the university said the same thing. We said, okay. So, while we were down there, first of all, we often spent the better part of 6 weeks doing our research, and it got a bit lonely, and once in a while you get the family down and so forth. We finally smartened up and said, why don't we take fourth-year students down with us? This would be, a real change of pace for them, but we'll also give them seminars and make sure we do this seriously as an educational effort. And they had a ball. It was almost a vacation compared to what they'd been doing hard work on the clinical services. But we made sure we, as we said, did seminars and antibiotics and so forth. In fact, when they came back one time, those students entered a statewide Jeopardy contest and did very well in it because we think of our tutelage while we were down there in Guadalajara. But yeah, it was great fun. You know, you really had a chance to get to know some students very closely and help them and mentor them in their careers. I mean, one of them is a notable ID, no more than one. One went to Yale for his fellowship, and now he's over at San Antonio. And the other is a guy that gives cutting-edge lectures, working currently in Nebraska. And to know that you've had that kind of influence on people and helping them achieve successful careers is very gratifying. You know? So those were fond memories, great memories. Well, the school, you know, was originally set up to train kind of family practitioners and generalists and so forth. I think clearly we've moved beyond that to become more of a top-tier medical school. So, and I think it'll continue to be able to grow along all fronts that way. You know, we have the senior leadership now. I mean, with the current dean, for instance, that I think we're quite capable of continuing to grow in those areas and just become a stellar medical school. And what does any stellar medical school ascribe, you know, and want to achieve? I think it's excellence along all fronts of service and research and teaching, and I think the tell of the table be the quality of our trainees as they go out. You know, I think we're going to see them get better fellowships later on in residencies. It's happened already. I mean, one of our students here, we were recurring interest in infectious diseases and wanted her to come here. Well, she's gone instead to an excellent other institution, and we think, gee, we're sorry to have lost her, but we're so proud that you went to an excellent school to represent us going forward. So I think that's developed and continues to develop. So I just think we're going to be recognized nationally as a school of excellence. And there's no one thing that's going to stand out. I think it's just the school is going to stand out, if I have any say in the matter. One thing that I had a finger in the early days was serving on the curriculum committee. And at that time, we were beginning to float this concept of, you know, giving a bunch of lectures is not maybe the best way for young minds to be learning. You can read fundamental stuff in a textbook if you give them time to do so. And lectures probably ought to be tying concepts together, cutting edge things that haven't made it to the textbooks yet, and learning how to think, kind of getting back to the original concept that we talked about. So, and that's beginning to happen in the new curriculum. I worry a little bit, but we'll wait and see what happens. Do students who have come up through college and university with this notion of going to lectures and memorizing a lot of stuff and putting it down on an exam, are they going to do well on tests that are designed that way if our curriculum is more teaching them to think rather than learning facts? They still have to learn the facts, and I think they'll have to make sure they understand that's on them now. Not the faculty is going to not be just spoon-feeding facts to you anymore. They're going to be helping you think about things. And I'm hoping that gets back around to less triage doctors and more people able to think about their patients. That's the hope. It's all, you know, big, important experiment in a way. But I think there's great hopes for that to occur. I continue to be enthusiastic about it. I'm just a little nervous about the test-taking issues. We'll see. But I think the students are smart, and they'll figure that out in a hurry, you know, and realize what they have to do to be successful, because they want to be successful, and we'll help them.